Welcome to this episode of the Future of Medicine podcast. I am your host, Dr. Wenzel. I am joined, as always, by Jen Justice.
Hello.
Good morning, Jen.
How are you?
I'm really outstanding, actually.
Glad to hear it.
I'm really excited about this episode. This episode is called Cardiovascular Update 2022, New Way versus Old Way. And we continue to talk a lot about heart disease in our practice. It shows up very often in our content, and I really thought it would be useful to put all of our thoughts together on one episode and in one place where we can give a high level but still useful tactical piece of content for our listeners around the number one killer of humans. And so I'm excited to jump in, and this will be a 3-part episode where we're going to kind of define heart disease and what I call the old way. The second part is going to be the new way, and then some action steps. So quickly defining heart disease. Heart disease is a term that a lot of people use. We're all universally afraid of it, as we should be. It's the number one killer of human beings. Kind of always has been, likely always will be, unless we have some profound breakthrough in behaviors, society, and science all at the same time. But essentially, heart disease at the highest level is a process of atherosclerosis, which is a hardening of arterial walls. Arterial walls are arteries that carry oxygenated blood to tissue, and it's the life source of being a human. So all tissue needs oxygen. Oxygen comes through blood, and blood travels through arteries. And when those arteries harden and they become enclosed through atherosclerosis, eventually plaques can form, minimizing blood flow. And where it gets really, really scary is where these plaques are unstable as they're forming. They can break off, and fragments can go downstream and get lodged in smaller arterioles and then stop all blood flow downstream, and that tissue dies. If that happens in the heart, we call that a heart attack. If it happens in the brain, we call it a stroke. I think part of the challenge of the old way of looking at heart disease is that you either have it or you don't. But the greater problem than that is the whole, you either have a disease or you don't have a disease. And one of the things we talk about is the disease spectrum. All diseases exist on a spectrum. The question isn't, do you have this disease spectrum? The question should be, where on the spectrum are you?
Right.
And by taking a very defensive posture, which is our old way of heart disease, we wait until there are symptoms and then we do something about it. And the problem with that is that by the time there's symptoms, by definition, you've got advanced disease. And this is why, after all of the years, all of the science, all of the breakthrough, all of the knowledge, we still aren't any closer to solving the preventing heart disease ambition than we were 25, 30 years ago, because we're taking a defensive posture. And we, you and I, and a group of other like-minded healthcare providers, I believe, are taking a much different approach than this defensive-minded mindset when it comes to killers of human beings. And to be honest, without a fresh approach, you will be managed in a defensive mindset, and it likely will lead to a non-ideal outcome when it comes to heart disease. Let's talk about the new way.
Okay.
How would you describe the way we do it, which we're calling the new way?
Well, first of all, in our model as a concierge practice, we have a little more flexibility and freedom to order some of the things that we do for our members, because we're not entirely bound by insurance constraints. So specifically specialized lab work that's on our intake labs that we look at for our members, and some diagnostic testing, which we'll talk about in a minute. So to your previous point, sometimes the old way is what it is because it's defined by those realities.
That's right.
And so you may be limited by only getting those tests in the old way, such as a baseline EKG, or a stress test if you're lucky, a basic lipid panel where they're just looking at total cholesterol
And screening you for symptoms.
Yeah, and screening you for symptoms. But I think where we take it to the next level is we look at it from more of an offensive standpoint, which we talked about in the last podcast, which was one of my favorites, is being hunters of things that take people off the planet and looking at the root cause. And so one of the root causes of heart disease is actually metabolic disease. And so on the spectrum of heart disease, like you already alluded to, you don't wake up and have diabetes. Like this has been a slow burn for a while. And maybe you just weren't screened properly to know your risk factors. But
all the signs were there if they would have been looked for and looked at.
One of the biggest risk factors for cardiovascular disease is actually insulin resistance.
That's right.
So if you think about it from a metabolic standpoint and reverse engineer that, some of the testing that we do and we look for is rooted in inflammation, in whether or not your body's processing insulin well, what is your triglyceride to HDL ratio, is your body processing carbohydrates and well at all? Where is that extra carbohydrate going? Is it turning into fat? Do you have fatty liver? Like all of these things. If we can eliminate the root cause and help you with that, then we lower your risk for heart disease. I think the other really big thing is your family history. So delving into, did your parents have an early cardiovascular event? What does their cholesterol profile look like? If you know, do they have high blood pressure? And when did that start to happen? What is your stress like? What is your sleep like? Measuring these things is really important. We use wearable tech to do that.
That's right.
We go for an aggressive weight loss stance. We want to eliminate visceral fat at all costs. We have a special machine that is able to tell us what your visceral fat is. And a lot of people don't know what that is, but it's that deep underlying fat around your organs. It's very pro-inflammatory.
That's right.
Puts you at a huge risk for heart disease. And we just want to attack that at all costs. So really, it's more of an offensive take on it. And you can kind of talk a little bit more about the specific tests and things that we look for in our members. But what I'm excited about for them and for everybody listening to this is 9 times out of 10, they're very cheap things that you can ask for, like inexpensive, even if you have to work around the insurance model. And if you know these numbers, you can make significant strides toward lowering your risk.
I couldn't agree more. I mean, I think, look, it is the way that it is. And a large contributor to the current state of things and the fact that we continue to play defensive-minded medicine is that we have a sick care model.
Yeah.
We're not designed, it's not designed to make you healthy. It's designed to keep you sick but not die.
Right.
Like, I mean, that's just the reality of it. And unless your sickness is bad enough to do something new treatment, new procedure, new drug, then you're being managed. It's a disease management system. We have the good fortune of being outside of that system and being able to actually do health care.
Right.
As opposed to sick care, which is 100% of the insurance-based model. And look, it's better than nothing, but like my hope is that this message would be encouraging to those who want, demand, can afford a better way, because there is a better way.
Yeah.
And for those who can't budget a service like ours, which, look, there's a lot of people who can't, and I'm super sympathetic to that. But I want to be able to equip you with what to ask for. Many times, if you ask for it in the right way, your provider can bill for it in a way that might get paid for. But even if it didn't, these are these spot tests that would be worth investing in your health. You cannot count on your insurance to have your best interest in mind. Their goals and your goals are not aligned.
Right.
They're just not.
And, if we were having this conversation 5 years from now and you had a cardiovascular event, I guarantee you would want to invest a couple $100 to get this test.
To know early.
Right.
To prevent bad outcomes.
Yeah.
And to see if there's still time on the spectrum to change the course. So this last section, I want to talk about the action steps that we need to be taking, that you need to be taking. And we're going to be providing kind of a cheat sheet in the show notes. where we kind of outline all of these things, kind of an old way versus a new way. As we look at all diseases, there are only two categories. There are modifiable and non-modifiable. We've talked about this in a lot of other content. Modifiable are things that you can actually modify. They tend to be behaviors like, do you smoke? Do you have high blood pressure? Do you have diabetes? Or do you have obesity? And are your lipid numbers all wonky? Is your diet off? Is your sleep? Those are modifiable. Non-modifiable are your genetics, your family history. I'm a man. I'm 47. I can't change that. Those are non-modifiable. Those have to just be managed, but we have to know about them. And when you look at the old or defensive mindset, when you look at modifiable risk factors, you basically, in the old way, we're forced to ignore borderline.
Right.
We normalize early disease, which is very dangerous, which is really the root of why we continue to have heart disease through the roof, is that we've normalized early disease. Borderline is not a thing, folks. If you're borderline, you have early disease.
Yeah.
By definition. And so we normalize disease. We manage the disease rather than put forth effort to reverse it, because that's where the incentivizations are. And then we just screen for symptoms. And if you don't have symptoms and we're normalizing early disease, then we carry on and everything looks fine. This is how, hey, did you hear about John? Yeah, I heard he had a big heart attack. Crazy thing is, the month before, he went to his cardiologist, said he had a normal EKG and everything looked fine. How'd that happen? They weren't hunting.
Right.
In the new offensive mindset, the modifiable risk factors, as you've touched on, these disease spectrums. Where is your fasting insulin? Where is your fasting glucose? Let's do a glucose tolerance test. Let's see if we've got any evidence of insulin resistance, that your body is not, your metabolic engines are not working well, so that we can help, support, reverse, optimize. We have to really understand the wearable tech. We love glucose monitors. Profound amount of information that can give you feedback on behavior and what my diet does to my blood sugars and what my sleep does to my blood sugars, and when I exercise, all of these things are super valuable, but they require an offensive mindset. So I would tell you that from a modifiable risk factor, the number one thing you can do is get your head around where you are on the insulin sensitivity spectrum. And the way we do that is we can grab wearable tech, a constant glucose monitor. Your annual blood work should, and besides the basic CBC, CMP, hemoglobin A1C, basic fasting lipid, we need to add your LDL particle number, or as an alternative, you can look at your ApoB. We need to know how many particle numbers of LDL you have, not just how much they weigh. We need to look at something called an Lp(a). This is a profound, very, very significant, we won't dive into the significance of it, but it's one of the most important tests that very few people are getting, Lp(a). You need to also be grabbing a fasting insulin, potentially a glucose tolerance test if you're really, really suspicious that there's some insulin resistance going on. And then what we have talked about in the past, an ApoE genotype. Again, we won't dive into the significance of this, but there'll be a cheat sheet, or you can write this down, ApoE as in echo. There is a particular type of, a genotype of ApoE called type 4 that we're uniquely interested in, because that is an inheritable risk factor for early cardiovascular disease. In the non-modifiable bucket, again, we've got things like age, gender, family history, genetics. We typically don't, in the old defensive way, it's kind of like, oh yeah, you're a man who's 55. Like, no, that's a real non-modifiable risk factor. And the older you get, age is the number one risk factor for heart disease. The older you get, the more likely you're going to get this disease of humans called atherosclerosis. But we need to screen for early accelerators. But, we have a fair number of people that don't know their family history.
Right. They're adopted.
They're either adopted or they have lost touch with their biologic parents. So it's really unclear. We're very clear on their modifiable risk factors. But thankfully, we've got things like the ApoE genotype. And if you have the means, you could do a full genome sequencing at this point. Now, it does take a couple $1,000 typically to get the full genomic sequencing, but that might be a really good one-time investment for you to get a real clear understanding, not just on heart disease risk based on your genetics, but cancer and sensitivity to medications and, early dementia and all these kind of things. These things exist, but we're always screening. And we're always taking into consideration these non-modifiable because we're on offense. We understand that these things matter, especially if you can't do anything about them.
Right.
You really need to have eyes on the things you can't change. And then we move into diagnostics. So diagnostics on the old way, I've mentioned the blood work. I mean, basic, $50 worth of blood work, a CBC, a CMP, a hemoglobin A1C, and a basic fasting lipid panel. That's better than nothing. But you've got to be able to add the LDL particle number, the LP(a), the fasting insulin, the ApoE genotype, and possibly some glucose tolerance testing. On the old way, from an imaging and testing, there isn't even a recommendation for a baseline EKG.
Right. It just blows my mind.
Blows my mind.
We get them on all of our members.
How you would not want to document the baseline rhythm of a human is beyond my comprehension. But nonetheless, if you're fortunate enough to have had a baseline EKG, that's really good. It's not really screening you for heart disease. It's just establishing a baseline. If you have symptoms or you're really, really high risk, but even without symptoms, you still may not even get a stress test. But a stress test EKG, if you're super fortunate, that's what you've been getting in the old defensive mindset. In the new way, there are things that are far more advanced and far more accurate and far more meaningful. For example, a calcium score. How many lives have we saved just getting a $100 CAT scan?
I mean, I can count them on both hands.
We go in there screening for heart disease and we end up finding aneurysms and tumors. And I mean, of course, you never want to find these things, but you would like to know early.
Yeah.
But a calcium score, everybody over 50 should be getting a baseline calcium score. We get them in patients in their 40s based on risk factor. But this is something that you should get as a baseline and then serial every 3, 5, 10 years based on your score, your risk factor, et cetera. This is too easy. This is a layup of something to do.
I recently got one, and it's 20 minutes. You're in and out. It's a low dose to radiation.
I got one too. Very low dose
I think
radiation.
It was $50 here in Nashville.
It's measuring the calcium burden of your coronary arteries, which are the arteries that feed your heart. And it's not perfect, but it is way useful when risk stratifying. If there's anything scary on the calcium score or your risk profile deems, there are new imagings, and we'll link to these. One called HeartFlow that we've been using for quite some time, and this is a very, very fancy computer-generated algorithm where we upload some incredible CAT scan images to the cloud, and the algorithm overlays and reads the flow of blood through your coronaries and assigns a numeric value to how much blood flow there is to tell you if there's any blockages that are of any clinical significance. This is really useful. It's like a virtual heart cath.
That's amazing.
Ridiculous. Now we've got an even newer technology. It's called Clearly, where it does something very similar to the HeartFlow, where it measures like a virtual cath the amount of blood flow, but it also tells you what the makeup of the heart plaque is, whether it's hard plaque or soft plaque. And hard plaque we know is much more stable. Think concrete, like a rock. It's unlikely to fracture, rupture, and cause problems. It's just a hard artery. Hard arteries usually don't cause problems. It's the swollen, inflamed, soft plaque that is very metabolically active, very unstable, and high likelihood of rupturing and creating a stroke, heart attack, blood clot, these kinds of things. And so you can have all of this data on the table with an offensive mindset, looking out on the horizon to, I mean, again, nobody wants to find these things, but if you got it, you want to know early.
Yeah. To make good decisions.
Correct. Then you intervene. If you need a heart cath, you need a stent, maybe you need bypass. Don't wait until, well, poor Johnny, Had we known last year, we could have gone in there and put a stent in this thing that took his life.
Yeah.
Or these 3 arteries were beyond repair. They needed to be bypassed. Let's go ahead and do that in advance. It's a bespoke, more tailored approach. And we get to operate in this world that is lovely and free of being bound by all of these rules. We just execute because our goals are aligned with our members.
Yeah.
If you don't have a practice like ours, you still have the power to ask for these things.
Yeah.
And you have a fair shot of at least getting them submitted to try to get paid for. But most of these things, with the exception of these fancy CAT scans, nothing in here is expensive.
Right.
We're talking, you handle more the cost of the, I mean, $100, $200 worth of labs. Not like, I mean, this is not, just ask for it.
Yeah.
Pay cash if they don't.
Right.
It's an investment in your future. So, I know that was a brain dump of like tons of things.
It was great.
But I think if you can listen to this again with the cheat sheet in front of you, really overlay this with you. What are your modifiable? What are your non-modifiable? What have you been getting and what looks okay? And where are you missing? Where are the holes in your risk stratification? You really need to know with more precision what your risk is for this disease that is the number one killer of humans.
Yeah. We have to at this point take this extremely seriously.
Unless you have no ambition of living a long time.
Right.
Or having a quality of life for the years that you do have. If you're not motivated, totally do you. That's fine.
Yeah.
But if you have ambition to play the second half of life beyond 50 at a high level with high vitality, minimal disease, high quality of life, and you don't have heart disease risk reduction way up at the tippy top, good luck.
Yeah. You will not win.
You're likely not. I mean, some people can sprint across a highway and not get hit.
Well, you know, we always hear about those 90-year-olds that smoked and drank and ate horribly and lived to be 90, and they're probably genetically disposed to do that, but not all of us are blessed in that way. And so
these are
we
outliers.
have to do this, yeah.
You know, every kid who wears a hoodie from Silicon Valley doesn't have the next billion-dollar company.
Right.
However, several billion-dollar companies have come from,
Right.
You know, that fit that kind of correlation. But when you play the laws of averages, and we were talking about your life, you want to go where the data is, where the science is, where the precision is, to give yourself the best odds of success.
And, you know, we talk a lot on our podcast about finding your person, finding your team. And this is one, if I could give any advice to anybody, it's find your team that will help you obliterate or at least know your risk factors for this.
Amen.
You know, if your primary care pushes back on ordering some of these blood tests, 9 times out of 10, it's probably because they don't want to order them. Because
Or they're not familiar with them?
Well, yes, or they just won't know what to do with the results when they get them back. So be your own hunter. Find somebody that knows about these things. Do investigation. If you have the means to switch physicians or find somebody, you know, some of these tests that we talk about need the specialist of cardiology. We have great ones here in Nashville that we lean on to help us with our members, but we had to find them.
That's right. Moral of the story is find your team.
Yeah.
This is just one more example, and it just happens to be one of the top 1, 2, or 3 subjects, you know, heart disease, cancer, dementia. Like, those are like the 3 scariest things for anybody who wants to live a long time. This has you've got to have more clarity and certainty on what your risk is or isn't as you march this thing out. I hope this is useful. I think we covered everything.
I think we did. This was a good one.
Any famous last words?
You know, as we're talking, I just think of the last podcast because you brought up a great terminology of delaying rather than preventing. I always think, you know, we always get hammered from media about preventing heart disease. That's really unrealistic.
And then when you end up with it, you feel like a failure.
Yeah. It's really about delaying it as much as possible. If I'm 90 and I die from heart disease, but I die quickly from it, I've won the game.
You win.
If I'm 50 and it's brewing and I don't do anything about it, I'm losing. So
by the way, every single 90-year-old on the planet has atherosclerosis.
Yeah.
Zero exceptions.
Right.
Some of them have heart disease, some of them don't.
Mm-hmm.
And it matters. And if that doesn't make sense to you, go back to our last episode where we really dig into what that really means.
Mm-hmm.
This is just, you want to be the 90-year-old with atherosclerosis and no heart disease.
Yeah. And I also want to thank you, Dr. Wenzel, as my colleague and physician, for digging into this. I mean, I didn't know, I wasn't taught anything about these things in school. And if I did, I clearly forgot them. But working here and having you really dig into the science, which, some of the science is 10, 15 years old, and it just gets looked over. But when you put all the pieces together, you're impacting lives, and I'm grateful for that.
Well, you're very, very welcome. I just care.
Yeah.
And I wasn't trained either.
Mm-hmm.
And my observation was that people kept getting sicker and sicker, and all I was doing was holding their hand as they got sicker, and I had to do something different.
Mm-hmm.
And there are a lot of physicians who share my conviction.
Mm-hmm.
I used to think I was alone in this. And in training, in a lot of ways, I was alone. But as I've been out on my own now, I'm starting to meet like-minded physicians who are going outside of the way the disease management, sick care model to hunt for health for their patients. And if you're listening to this and you're not convinced that you have the right team, I promise you, wherever you are, there are physicians in your market who care.
Yeah.
And it may not be obvious. And I wish it was better, and I wish there was more of them, and I wish there was an easy way to identify them. And there may or may not be. But ask, hunt, own your own health. Be the CEO of your health.
Oh, amen.
Right?
Mm-hmm.
It's not fair. I wish it was better. It's not ideal. But at the end of the day, this is the only lap around the track you get.
That's right.
And if you're not convinced you have the right team, hunt for them. So, all right. I hope this was useful. Share it, comment. Let us know. And until we see you next time, take care.